Good morning. Good morning. How you doing? Are you feeling good? I feel great. It's another beautiful Saturday. What better place would you want to spend in La Jolla on a Saturday than in a prostate cancer meeting, right? Yay! I'm George Johnson. I'm one of the volunteers here. We have a magnificent 9. We got one more opening in case somebody wants to volunteer. Okay, welcome. And we're very thankful for these wonderful facilities. And I know you'll keep it clean. And if you need some other facilities, we have it down back door, down the hall, a quarter of a mile, and you'll find the men's room down there. I know I don't want to mention it's a long way, so don't delay. You know, I know what you go through. But we're very thankful that you could be here today. We got a wonderful speaker, and here your host. Hey, this is a magnificent 9, and we got Lyle here. Raise your hand, Lyle. And Gene, here we go, Gene. And I'm George, and we got Bill Manning back there with the black box with the red light on it. He's our videographer. We got John Tassi. Is John here today? No, he's not. Okay. Bill Bailey's here. He's back. There he is, our librarian. And Steve, where are you, Steve? Raise your hand here. He's our editor-in-chief of our newsletter. And then we got Bill Lewis. Bill's here, and Bill does the summary of the talk, does a great job at that. And then the guy with the smile, is he here today? There he is. There's Jim. Okay.
Here for the first time in the yellow sheet.
Okay. Okay, you got a newcomer package. I want you to fill out the front page, and we'll gather that together. And you get a call from Gene in case you got any questions. Welcome you aboard. And there's a lot of good stuff in there on basic information about prostate cancer and a glossary of terms and some interesting articles and things of that nature. So you want to review that. Okay, our support group purpose. We're here as patients. We want you to become your own case manager. I can't help but emphasize that. You're responsible for your own case, not your doctor. You have your own quality of life issues. You know what side effects concern you. And so the whole purpose of this program is for you to network, not only and listen to our presenters, but to formulate questions you want to ask your doctor. Doctors tend to think particularly urologists, they will let you know what they think you ought to know. That may not coincide with what you want to know. So be sure to ask questions. And that's one of the functions of this group. Give you some questions to ask your doctor, because we're not a substitute for your doctor at all. What you hear here is only some views and opinions. So we don't suggest any treatment or anything like that. So we want you to talk to your doctor and ask him questions. Okay, what do we got going for you? We have a website that's got some corny jokes about prostate cancer, if you need that to cheer you up, and from really good technical articles, and also a summary of the previous talk. And now we got a library down here. Look at this list of books here. Fantastic grouping of books. Books you can rent for a month, DVDs you can rent for a month, and others that you can buy, and you get a special discount price, and we make money off of that, which is a good idea too. We got a newsletter that you've heard about, and we have an outreach program. We're dependent upon you guys to talk to your friends and neighbors and your peers. Because if you got prostate cancer, 1 out of 6 of your buddies got prostate cancer too, or will get it. So get the literature out front, pass it around. And particularly if you have a son who's now getting to be 50, the fact that you got prostate cancer, it's likely that your son may have it too. If he's 50, he should have a PSA test. So it's very important for you to reach out to your fellow men and have them participate in our program. And then we have monthly meetings. Dum-da-dum, next month, backed by popular demand, as they say in Vegas, we have Richard Lamb. And he's going to give us an overview of immunotherapy or immune therapy and what's going on. He gives a really good summary. This is our year end. We don't meet in December. This is our final for the year, and you don't want to miss that. Okay, we're going to do our survey, and I want you to raise your hand. And this is for the newcomers as well as for our speakers to get a kind of a scan of this group. And what we see in this over a period of time is the shift in treatments and activity. So let's do that now. How many are here for the first time? Raise your hand, please. Okay, once you know you're welcome, I want you to come back. The purpose of our group is to keep you informed, so you got to keep coming back. Okay, and don't forget to fill out that cover sheet. How many have been recently diagnosed in the last 6 months? Raise your hand. Okay, so you're puzzled about what to do, or maybe it's very clear to you. If not, let's see how far we can go, dear. How many have had prostate cancer for up to 1 year? Raise your hand, please. Okay, we got a lot of old timers then. How many up to 4 years? Raise your hand. Okay, 5 to 10 years. Look at those hands. See your newcomers. See those hands up there? 11 to 15 years. Raise your hand. See? Okay, anybody above 15? Yes, how many? 18. 20. Anybody go higher? 18. I got 20. And Jack is not here. He's got 27. So this program works if you work it. Okay, now let's talk about Gleason score. This is a very key number. Do you know your Gleason score? This is critical because it determines what kind of treatment you want to have. Okay, I'm going to go down the list. We have the score, which is the sum of two numbers. And if you got a 6 or less, you're very low risk. And that's where active surveillance and things that open up non-invasive techniques and activity for you. So how many have a 6 or less as their Gleason? Raise your hand, please. You're very fortunate. Okay, how many have a 7, a low 7? This is intermediate risk. Okay, so that's 3 plus 7. How many have a high 7? 4 plus 3. Okay, now what I learned up at the PCRI conference, our speaker was up there too, is if you've got a 3 plus 4 or 4 plus 3, it's a good idea to get a second opinion. Have your doctor send those slides to Johns Hopkins or wherever else. Independent, not within the same HMO, independent of that, because this is a critical difference, whether maybe you got 2 4s rather than a 3 and a 4. So that's critical, because then when you get a 4, now you're entering the high risk. How many have an 8? Raise your hand, please. Okay, let me see how many, well, okay. How many have a 9? I got a 9. Okay. You had an 8 and a 9, huh?
Depends on which biopsy.
All right. So 8 and 9 is a 17, okay? No. Okay, let's see the 9s. How many got 9? How many we got here? 1, 2, 3, 4, 5. 5, okay. How many have a 10? No 10s, okay. As I mentioned, this is important, and you should be tracking that, what's happening here.
What about the new scoring? Has that gone into effect?
No, it has not, and that's going to take a while. Doctors are slow to change, and so that's a suggestion. It has to go through all kinds of committees, as you can appreciate. But it's to simplify what is asked. We talked about this a couple of months ago. A 6 sounds high, so they want to change it so a 6 is a 1. And the maximum is a 5, and so sort of normal for our other kinds of detection. Okay, let's do our traditional treatment survey. Those of you who have not had any treatment but are under active surveillance, raise your hand. Now see how that's growing over the years. Okay, how many have had prostate surgery? Raise your hand. Now if you've had other things, raise your hand too. That has been the gold standard. I have not had that. Okay, how about radiation of all kinds for prostate? And see, that's become more common now. Okay, let's do ADT for those who I now probably got ADT. I'm on that. We got a lot on ADT. Chemotherapy. How many are on chemotherapy? 1, 2, 3. Okay, and John, if you were here before. New treatments. Let me do a little rundown. How many are on Zytiga? Raise your hand, please. One. I got it. 2, 3, 4, 5. How many are on Xtandi? 1, 2. That's it, huh? Okay. Zofigo. How many are on Zofigo? Notice how he raises his hand every time? He's had everything. And look how happy he is.
I just don't know any better.
Zofigo. How many are on Zofigo? Okay. You're it. Huh? Yeah? Okay. Provenge. How many are on Provenge? Look at that hand go up again there. Okay, you're on Provenge. How's it doing for you? Okay. All right. I'd like to hear about those after the meeting. Please come see me on that. All right. Let's do recurrence. How many have recurrence? All right. Keytruda. How many are on Keytruda? Say, okay, we got 2 on Keytruda. Yeah. I mean, this stuff is not cheap. I checked on Zytiga. That's $10,000 a month. Xtandi is $10,000 a month. Extruda is what? $20,000 a month? Free. It's free for you, yeah.
So far it's furnished.
Yeah, he's frugal, you can tell. Okay.
So far it's furnished by the
Right. These new things are not cheap, and that's why the concern is about the rising cost. Now, let's go back to recurrence. Raise your hand if you had recurrence. Now, some of you may be surprised. Look how many have every recurrence. Now, if you have recurrence, the question is, where is your cancer? Where is it? It's somewhere there because your PSA is rising. And that's the key thing. That's why we got today's speaker. He's going to tell you how the diagnostic imaging can tell you where it is. I don't know if you realize, not long ago, they used to do exploratory surgery for prostate cancer if they couldn't find it. Or they would radiate the whole pelvic region. We're not doing that as much anymore. That's the good news. Okay, how many are undecided what to do next? Okay, you're in the right place. And for those of you who have a question about these things after the meeting, I'll be down in front. But I'm sure you're going to have a lot of questions for Dr. Almeida, and he'll be up here at the end of the meeting. Okay, since we're talking about diagnostic imaging, let's kind of do a review. We've never done this before, so you might want to scan the audience here. Okay, I had cancer detected 20 years ago. And back then, after I had a biopsy, the urologist said, well, okay, you need to have a CT scan and a bone scan. That was the tradition back then. And maybe it still is today. How many have had a CT scan? Raise your hand. Look at that. See? How many had the bone scan? Now, I'm talking, okay, the bone scan is technetium-99, and they inject you, and an hour later you go back in. How many raise your hand on the bone scan? How many found out that they had a problem after the bone scan? Look at that. Look at that. Why is that? Well, I remember when I showed Dr. Almeida my bone scan, and he laughed. Because if you're old, that bone scan's got black marks all over the place. Wherever you broke something or fell or arthritis, you had the, and he laughed at it. You know, that's typical. It's not that good for detecting, early detection of prostate cancer. It's good for detecting maybe when it's too late. So that's why the old bone scan is not an assurance that...
give you my slides and you just take my lecture right and you're just...
Yeah. So, I mean, those were the old days. Now what happened, we got Color Doppler Ultrasound. How many have Color Doppler? Boy, this goes back to Tucson, and I got a color Doppler, and also up there the prostate cancer oncologist, the specialist up there, Marina Del Rey, they do the color Doppler, and that was a breakthrough in terms of really being able to detect the cancer in the blood flow and do a better job so you could get a targeted biopsy. Urologists use the general ultrasound just to find the prostate, not to locate the tumor. This color Doppler helped them, and this is a wonderful craft that unfortunately not many urologists have. And how many have had a color Doppler in the last year? See, it's kind of fading, and is Duke Bond still practicing? I don't think so. Okay. He's the guy that trained Lamb and Schultz and so forth on color Doppler, a special guy, and I learned about him in this meeting, and he helped me greatly. Okay, now, MRI of all kinds for prostate cancer. See, okay, look at that. Now that's become the standard. Now let me ask you, how many have had the new multi-parametric Tesla 3 MRI? I've had that. So that's the new one, and we're going to talk about that. Okay. And, okay, now let's go to F18 sodium fluoride PET scan. How many have had that? 3 years? Okay. All right. Okay. Now, C11 choline, which is really only available at the Mayo Clinic. How many have had the C11? One? Anybody else? Okay, Larry, you're unique. Yeah. Okay, now let's do the C11-Acetate. Raise your hand if you had that. Now, I bet I can tell you where you had it. Huh? Just to show how smart I am, I bet you had it in Phoenix, right? That's about the only place now. We used to get it in Kansas, but now you're it, right? Okay. And so we're going to hear some more about that. And now we're into some new stuff, Axumin. How many have had Axumin? 1, 2, 3. Anybody has 3? That's it? Wow, I'm sort of surprised. Okay, now the gallium PSMA. Okay, 1, 2, 3. 3. Okay. See, these are the new ones. These are hard to qualify. I don't qualify for these last two. Okay, hope that's been kind of informative for you. Okay, we need your support. We need your money. You're going to regret you didn't give more come April 15th. And this is your last couple of months to really dig deep. And we got small baskets, so that's why we like big bills. And pass them around. A big bill has a 0 on it. A 1 and a 0, or even maybe a 2 and a 0. 2 zeros, you get a bonus package with that. But dig as deep as you can, because this program is costly to run. And all our efforts are just volunteers at no cost to you. So we have, it's tax exempt, no medical or religious affiliations. So while you guys are passing that basket, let me just summarize the 6 basic principles of managing your case. 1, early detection. Get that PSA test. Don't believe the task force study. They're trying to save the government money. Get that test. If you're 70, get it, because then you get a benchmark, which you can refer back to and see what's going on. And if your parents or your father had prostate cancer, you should be getting it at 45, that test done. Okay, now what's important is high definition diagnostics. And that's what we're going to hear about today. Because if you've got that, you can find the prostate and the tumor, and then you can do number 3, a targeted biopsy. Rather than just doing a random core, which is standard down here in San Diego, 12 needles go in there at random in a grid, may miss the key tumor. So you want a targeted biopsy and then know your Gleason score. And because that's important to do, if you have a number 6 or less, you can do active surveillance. And active surveillance has really fantastic results. And the recent studies have shown how effective it is. And then you got treatment selection. And that's a lot depending upon your Gleason. Okay, today's agenda, Fabio Almeida. Now, I got from here the introduction for him from the PCRA conference. He was a major speaker there. And it says, Dr. Almeida is one of the pioneers in the development and implementation of cross-modality fusion for cancer imaging. Cross-modality infusion. Isn't that impressive? Huh? Right. Now, I could read his CV. No, I want to share with you a personal experience. After I saw Duke Bond, and he found that he did a biopsy of my seminal vesicles. It's rather rare to do that. He did it, found I had an 8 in my seminal vesicles. What am I going to do? After a couple of years, I started to worry. Went to an oncologist, and he said, why are you here? I said, well, I'm worried. He said, well, what are you worried about? I said, it may have spread. Well, what are you going to do about it? He said. I said, well, I don't know. And if it's spread, I'd like to know where it is. Well, if we knew where it was, no one would touch you, no doctor would touch you, no surgeon would touch you. I said, why not? He said, well, because of your age and your heart. And I'm looking for, where is it? Because my PSA was rising. And then, due to Gene's attention to what's going on in the world. Now, this was what, 4 or 5 years ago you came in here? 5 years ago, he came in here, knocked our socks off. We had some slides showing how he can detect prostate cancer in soft tissue. Where up to that time, it was shades of gray. Maybe it's a tumor, maybe it's not. We don't know if it's cancer or whatever. Here, he had this technology, so I went down there. And because I was afraid what might have happened, I scheduled a week vacation up in Monument Valley above Phoenix, Arizona. So I went to see this wonderful person. He sat me down, he talked with me, and then I went and had a scan, and I had my wife with me, and he talked to her. And after the scan, we went into almost looked like Houston Mission Control. There's these wonderful displays, and he sat down for an hour and went through it with me and comforted me greatly. He says, yes, George, it's in the seminal vesicles, and it's down at the base of the seminal vesicles, which is a good sign. It's not that serious, and it's only on the right side, and that's good news, too. Now we have a benchmark, and now we can track it thereafter. And what a relief that was. Oh, my gosh, I felt so much better. The anxiety was reduced. I have a benchmark and go back and see how things are doing, which I intend to do, and so forth. I just wanted to share with you what a wonderful it is to have a doctor who has care and gives you the time and attention, and that's what he's done for me, and I know he's done it for you, too. So it's a great honor to have Fabio Almeida come up here and share with us what's going on and what's new.
All right, so this is my 5th year, I think, being here. 6th year, wow. So I'm going to talk certainly about imaging, because that's mostly what I do. We're going to talk about a number of different things. Definitely feel like part of the family here. There are a lot of familiar faces, both people I've seen here each time and obviously those who have come to see me. For the benefit of those who are new, because those of you who have heard this year after year with the carbon acetate, this is kind of more of a continuing medical education seminar for you, just to see, well, where are you now, and you as you're following. But we'll have a lot of terminology and kind of got to bring everybody else up to speed as to where this technology has led us, and now there's a lot of new technology out there that we need to look at, and we'll run through it. All right, so while we're getting this thing started, one of the things that I think is very interesting to see also with the evolution is with taking the poll on different therapies and everything that people have been on, all of these therapies have been relatively new last 5 years, or 6 years. So the Provenge, the Xtandi, the Zytiga, and so we've just really seen a lot of evolution with prostate cancer, both from the imaging and just all the different treatments. And at the end of this, we're going to be talking about probably one of the next treatments that's going to be coming up to be aware of. Okay, so I'm the medical director for Phoenix Molecular Imaging. I came from the University of Arizona. I was the medical director there. We started doing some molecular imaging work there, ran into politics, bureaucracy, inability to get things done quickly. So I left. We started our own center. And Cardinal Health was very instrumental. And actually, they do the legwork in the isotope work that I do. So they've made everything possible. And in the last year, now I'm actually part of Insight Imaging, just so you all know that. So I do not only nuclear medicine, but multi-parametric MRI, ultrasound, breast imaging. We do everything through multiple centers in Phoenix. Part of the reason that I did that is Insight is a national group, and in order to really get information out there, kind of like the information I'm letting you know about, we have to educate the physicians. Most of our physicians really are getting educated about molecular imaging through the patients, which is really kind of interesting. So you're my crew out there to educate the docs, but it's one of those things that the information really isn't very useful if people don't know it. And docs are very slow to adopt new technology, so it certainly takes some time. Okay, so we are going to talk briefly about multiparametric MRI and sodium fluoride. We'll spend some time with Axumin, acetate, and choline. These are basically predominantly PET imaging agents. So these are done through a technique that's positron emission tomography. So a small amount of radiation that's given to a ligand that's injected in. We let it circulate for a little bit. I'm sorry, this seems like it's cutting in and out. Is that okay? Okay. So it's actually a very easy imaging technique. People can tolerate it much easier than MRI. Most imaging takes about 20 minutes, but it really is dependent on, for the most part, these agents are radioactive, and for the most part, they need to be generated with a cyclotron, which means that they're done. Some of these are done in very specialty sites, because you have to have proximity to it. That's really for the carbon acetate and carbon choline. Those are the most notorious ones we'll talk about as far as logistics. Then we're going to spend some time talking about PSMA, which is really the next thing that's coming. Oh, hey, there you go. All right, so multiparametric MRI. MRI as a technology, doesn't use any radiation, uses essentially electromagnetics, is a very good tool for us to look at the prostate gland. Of all the imaging we do, CT scanning, ultrasound, and everything else, MRI has the ability to see tissues in the body better than anything else. We can distinguish really small structures in the body, and particularly for the prostate gland, because there's a couple different zones in the anatomy there, MRI is superior to everything else. Part of the problem, though, is it is anatomic imaging. So we're looking for changes in anatomy for the most part. That's with a standard MRI. Now, what's happened in the last few years is we've added different parameters to these, or sequences, that allow us to see things a little bit differently with the MRI, and we're going to talk a little bit more specifically about them. But it's given us some additional tools that when we do these multi-parametric MRI, we get a lot of insight as to what's going on in the prostate gland and some very, very good definition. So this is something that has been really now positioned for us to use early on. So when someone is initially diagnosed, or when we see a rising PSA and we're trying to figure out whether there is prostate cancer or not, instead of doing color Doppler, which very powerful tool, but it's user dependent. The technician or the doctor has to be very good at doing the ultrasound, otherwise it's not a good test. The multiparametric MRI, or MRI in general, is much more standardized, so that we're getting that same kind of definition that we got from the color Doppler. Now we're getting with MRI, and hopefully in a much more standardized way. When we do see things on that kind of test, then we have a nice target to know where to do the biopsy. So as a tool for helping us with targeted biopsy, it's much better than doing the standard sextant, or six biopsies on each side of the gland, which might miss. So some of the indications for this, I throw this in here actually. We'll go. Oops. I think one would argue that even with an elevated PSA, even before you have a negative trans rectal ultrasound guided biopsy, that you kind of start a the MRI and go for a targeted biopsy. That's what I would encourage. But the urologists very much resist that. They want to do at least a standard biopsy first, and if it comes back positive, then they feel like they have the information, or then they'll send you for an MRI to see if there's a different targeted lesion to go after. And this is one I go along with this only because I don't want to see the MRI not get adopted. And so part of it is over time we have to work with the urology community to make this integrated into the care, and they're the gatekeepers pretty much for this. All right, so then also once this diagnosis is established for the lower grade cancers, Gleason 6, a low grade Gleason 7, so a 3+4 that might have a small volume that's not multiple different areas in the gland, MRI is very good for then us to follow the gland. So for active surveillance, so we can measure the size of it, and we can also measure how vascular the lesion is, and that has really now become the way of watching these cancers very effectively. So give you an example. This is all the same patient here. So this is the prostate gland in cross section. So this is the front part, this is the back, this dark area here, this is the rectum, and the prostate gland. This whole thing is the prostate gland. The area that we're usually concerned about in prostate is this peripheral zone. Okay, so it kind of looks like a croissant, sitting here, and there's this what's called the central or transitional zone here. The idea with this is we're mostly looking at this peripheral zone. That's about 70% of cancers happen in that area. Cancers can happen in this more packed glandular area. It can be really tough for us to see with ultrasound, and actually very difficult for us to biopsy. Also still a challenge even with MRI. But in this particular patient, you see this dark area here, pretty easy to see. It also looks like it's bulging out a little bit beyond the edge of the gland. So this is what we're looking for with an MRI. So something that can be pretty easily seen, and given the proximity here then to the rectum, easily biopsied. So this is looking at the gland from front to back. So kind of looks like a heart shape here. We're essentially looking at this portion from front to back, and there's that lesion. And this is looking at from side to side. So this is front, this is back, so this is the rectum here. And so we get really good definition in 3 dimensions for where these tumors are. So just a really fascinating technique that's been very helpful. A lot of the imaging that I traditionally do is for recurrence or later stage cancer, and we've really moved in our centers to doing a lot of multiparametric MRI because we kind of need to cover prostate cancer from beginning to end as far as really having good imaging. Okay, so a little bit about technetium bone scans and sodium fluoride bone scans. So my bias against technetium bone scans has already been exposed. I've done thousands and thousands of technetium bone scans. This is what we're looking at here. This is a technetium bone scan looking from at the front and the back. It's a 2-dimensional imaging study inherently done with what's called a gamma camera. The real problem with this is a great kind of study to do on a 14-year-old athlete who we're worried about something like spondylolisthesis, where they've essentially fractured a small bone, a pars articularis fracture, very common in gymnasts and other athletes, because the rest of their bone should absolutely look perfect. And on the bone scan, any little spot that lights up, we know they fractured it. Well, in someone 45, I'm going to even say 30, because football injuries earlier on, when you get older, you're going to have arthritic changes, you're going to have old trauma. It doesn't take much of a bump to a rib to make a little bit of trauma. So these scans are notoriously lighting up in older people, and so we're confused most of the time when we look at these scans. So the other aspect of this, even if we do see prostate cancer with technetium bone scans, the lesions have to be 1 centimeter to 1.5 centimeters in size for us to pick them up. So it's a pretty big size lesion in the bone. Okay, so this is an example. This gentleman here, PSA is pretty low, 0.84. He's someone who is, we're worried about a recurrence. He'd had definitive treatment before. And this bone scan showed this bright spot here, looking in the back along the lower edge of the spine. And this was read out as, well, this is probably some arthritic or degenerative change, because it's right next to where we usually see areas of a joint. And otherwise, the bone scan looked negative. So it was called negative, probably degenerative change. So the scan that's next to this is a sodium fluoride bone scan. Both of these scans are looking at what's called a calcium mimetic. That's using an agent that essentially tracks calcium. So this one is technetium-99, and this one is sodium fluoride. The difference is a PET imaging agent, which allows us to do a three-dimensional image, and the resolution of this is much greater. And also, it's done with a CT scan at the same time, so we anatomically know where we are in all three dimensions. So that same spot that was lighting up here, you can see how brightly it lights up on this here. And when we look at it to triangulate on the actual cross-section, it's not in the joint, but it's in a part of the bone that's called the lamina, so the little area in the bone marrow. So this is in the bone, not on the edge or in the joint. So that's a metastasis. That's cancer that has spread there. And then also just a little further down, there's another spot that's within the bone marrow, a little bit lower. So this changed the diagnosis from, well, it's negative, probably degenerative changes, to we've got at least 2 bone metastases. So that's a pretty big difference. The resolution on the PET scan, we routinely see small lesions down to 2 millimeters. The other aspect of this is then the negative predictive value. So when we see a bone scan, sodium fluoride bone scan, and it is clean as far as we really don't see anything other than arthritic changes, it has a prediction that it is truly negative, so that we're not missing something. Where even if I saw something on a technetium bone scan that was positive, and I saw one spot there, we say, well, it's probably just the tip of the iceberg, because I'm only going to see the largest lesion, and there's probably a lot otherwise there that I wouldn't see. This scan actually has enough accuracy on it that we do much better of saying, yes, it is positive, or really it's negative. And I think that's important. A lot of the agents I'm going to talk about subsequently, they're good in bone, but they work differently in how we evaluate the bone. And having a negative sodium fluoride bone scan before we even start doing those other scans is really important. It gives us just much more confidence in the direction we're going to go with treatment. Okay, so a little discussion about Axumin. So all the next agents we're going to talk about, these are also PET agents, and they are radioactive materials that have been attached to some kind of molecule, either amino acid or a fatty acid constituent. We're going to talk a little bit about a small molecular proteins, the PSMAs. So Axumin, this is an agent that I think I started talking about this one about 4 years ago. It was called Fluciclovine, or we used to call it FACBAC, FACBC. So they migrated to Axumin. Got FDA approved last year, I believe in about September. So a lot of momentum with it. This is a fluorinated altered leucine. So it's an amino acid. And the idea with this agent is that prostate cancer will upregulate. I don't know if I'm doing that or not. Maybe I just. What was that? So, okay, maybe it's me. So the idea is that prostate cancer has upregulated its amino acid metabolism. So as part of any cancer, cancers need nutrients, sugars, they need fatty acids, they need amino acids as building blocks. And so when we find with certain cancers, yeah, I'm not touching it, so it's not me. Certain cancers have different pathways. For most other cancers, we do FDG, fluorinated glucose. So for breast cancer, lymphoma, colon cancer, lung cancer, it's very, very effective. Prostate cancer doesn't pull in enough of sugar or change its sugar metabolism such that we can use that technique, so we had to look for other things. So Axumin right now, it's available. And the images I'm going to be showing you in a bit are very similar to what we see with carbon acetate. But there's some things just to know about it. This is probably the largest study that came out this year looking at multiple centers, a little under 600 patients. So 596. Wow. No one has any epilepsy here. I'm not going to cause flashing lights here. So we're going to run through some of the things in here. When we look at these imaging studies, we have to kind of understand a little bit about their statistics or their detection rates, so I'm going to be highlighting a little bit of that. So in this particular study, under 600 patients, this was in 4 different sites, so a reasonably large study. The overall detection rate, was a little under 70%, so 68% about. What that means is they saw a scan, somebody called it positive. Okay, so that's the detection rate. When they actually then look to see how often they were right, so I see something lighting up, we do a biopsy, or we follow it up to prove that it actually is prostate cancer, that overall value was 62%. So this is what's called the positive predictive value, or PPV. This is probably a more important number than this, but one of the things that has been a little bit, and as we kind of go forward with some of the other numbers from the other studies, highlight why this is important. This is not great. So it's saying that about 70% of the time it's positive, so it means 30% of the time this test was negative. And this test was done on patients who had a rising PSA. So there should be no false negatives. Everybody has a rising PSA. Ideally should be 100. So there should be no true negatives, I should say, in these patients, because nobody had no prostate cancer. Now, when we look at the positive predictive value, then it tells you of this 70%, only 62% of the time were they actually able to demonstrate that it was prostate cancer. So that means the false positive rate was kind of high. Part of the reason I'm bringing this up, I mean, this is much better than we've had in the past with other tests, certainly with the CT scan or technetium bone scan. This is a huge leg up. But these numbers are disappointing in that we're looking for subtleties. You're looking at probably about 50% of the time when you do one of these studies, it's not going to pan out. It's not going to give us an answer. Now, if the study was inexpensive, if it was easy to do, had no radiation, I think that wouldn't be that a bad of a thing. But Axumin is expensive. There's fluorine radioactivity associated with it. So I'd like these numbers to be a little bit better. Recently, 2 weeks ago, I was in Dallas and I was giving a talk to 60 medical oncologists who I would say in this group, you all know more about this imaging than that group of 60 medical oncologists. But I polled those who were out there who were more of the urologic ones that had some familiarity with this, and they pretty much had said, yeah, it's about 50% pickup. I've had that conversation with Mark Schultz and with Snuffy Myers, and they said, yeah, it's about 50%. So half the time you send, no matter what the PSA is, it's going to miss. So that's a little concerning to me, and it's something just to be aware of that there's some things that maybe we can do to tweak this imaging to be a little bit better, but it's not as great as I'd like to see. So in my opinion, I don't think it's going to be around for very long, probably a year or two, and I think we're going to move on to something else. So this is just some imaging of the Axumin. Okay, so just in 3 different people. This is kind of more of what I want to see as far as the biodistribution. With this, we see a lot in the liver. So this big thing here is the liver. Here's the pancreas. We see the heart. We see a certain amount of nothing, bone marrow, and a little bit of intestines. So this is. So one of the problems with an amino acid, I have to just talk quickly between the slides here, is amino acids will go into the muscle. And so this has been one of the problems with Axumin, is that sometimes we get the muscle scan. And for those of you who've been to my center, we have you stay away from doing kind of any exertion for 3 days before you come and get a carbon acetate. Because the carbon studies, or the acetate, also can go to the muscles. But we're usually able to control that just by having people become a couch potato for a couple of days. Unfortunately, we've done the same thing with Axumin. So all 3 of these are patients that I've scanned. So we controlled the protocol very tightly. And so everybody did exactly what we do with carbon acetate. They really didn't have any exertion. But we still saw some people where we could not get the muscle activity to go away. And we don't have a good explanation for that. That really interferes with the quality of the study. All right. So carbon acetate, full disclosure here, this is my work here. So, you can take a look at the paper. Mark Schultz and Richard Lamb, as well as some other folks in town where I am, were also contributors to this. So this is at our lab looking at carbon acetate in patients with rising PSAs. generally patients who had negative bone scans, negative technetium or sodium fluoride bone scans, negative CT scans. So looking for early recurrence. Not all of them, but that's the majority of these patients. Looking at 721 patients. And what we have found is our overall detection rate across the board for these patients is 88%. And that's actually, what's interesting for those of you who've seen this lecture before, when I came here, I think the first slide I had, we had 30 patients. And the detection rate was 88%. Now we have 1,800 patients, and the detection rate has remained very solid. So part of that is anytime we look at a study with small numbers, we are not sure, are we just getting things by chance? And that's when we start doing things with much larger numbers of people. If the statistics hold, then they're much more believable. So the other aspect with the carbon acetate is the positive predictive value has been 91%. And the way we've achieved that is, or determined that is, we saw a lesion. In a number of people, we did biopsies, so we got pathology to confirm it. We have a large subset of patients who had focal radiation just to the spot we identified and nothing else. And if the PSA responded, we were very confident that we were actually dealing with prostate cancer. And also we looked at patients over, for those who didn't have those other two parameters, those patients that we could follow with imaging in their clinical course. And if they obviously manifested what looked like prostate cancer, we counted that as a positive. And so for us, this was done over about 350 patients where we had all those pieces of data. So positive predictive value has been very high. So we're going to talk a little bit about also with the PSA thresholds. This is looking at this kind of study overall. And actually, 1,800 now on that. Overall detection rate of 88%, 91 on the positive predictive value. But there is a difference in where the PSA is. So we just look at absolute PSA when PSA is rising in a recurrent setting. When it's over 1, the test was positive more often. When the PSA was less than 1, or 0.2 to 1.0, 74% of the time. Axumin in that range runs probably about 20 to 40%. So it's a big difference that we're seeing. And I'll say I'm very disappointed with Axumin mostly because I helped them get funded. So I got them kickstart for them, and I was very hopeful that we would actually stop doing acetate and we would be moving on to Axumin by now, and it just hasn't panned out. Okay, so the other thing that we then looked at is with these patients is, well, we have an absolute number. So we're using it as a threshold. The reason that's important is when somebody calls me up and says, okay, my PSA is rising, and I want to know that number, is because I want to gauge, well, is this the right time to do the study? Or are we premature in it? Because if we're going to do an imaging study, we want to maximize the chances that we're actually going to find what we're looking for, rather than getting in ahead of time. But one of the other things that we've really looked at was the dynamics, the doubling time or the PSA kinetics. So we found that not only does the number matter of whether it's above or below 1, but also what the doubling time is. So if the doubling time was brisk, so the PSA is moving pretty quickly, so doubling every 3 months or less, the detection rate was 90%. If it was moving relatively slow, greater than 10 months, you can see a big drop. So we used this to analyze then the patients that had a PSA of less than 1, and as far as determining what that positive predictive value is when the PSA is less than 1. And so, and come up with a kind of where our sweet spot is here. So it's about 3.8 to 4 months is my recommendation, at least on doing carbon acetate, and pretty much this is translatable to carbon choline and also PSMA studies, is even if the PSA is very low, if it's got momentum, it's a reasonable thing to do. But if it's very low and it's moving slow, we need to wait it out, or we just need to keep an eye on things. Okay, so some examples of what these things look like. So the PET imaging is a CT scan combined with the molecular imaging on top of it, and essentially the red or the pinkish areas, that's carbon acetate overlaid on top of the CT. This is a gentleman who had a prostatectomy. He was a Gleason 8 with a PSA of 4. He had gotten down to undetectable. We're using more and more of the ultrasensitive PSAs, so we don't see these kind of numbers reported out as often. Now they're usually 0.03 or 0.001, but less than 0.1. And he was there for a number of years, and the PSA started to rise. It was 3.3, doubling time, actually moving pretty quickly. I thought that was a little slower. It actually should be, it's cut off. It's 10.9 months, so that's 11 months. So that's actually relatively slow. And the carbon acetate imaging, this is the prostate bit here. So we're looking at the front here. This is the back. This side is right. This is left. These are the top of the femurs. These are pelvic bones here. Here's the rectum. And the bladder would be above the level we're here. And so here's the prostate bed. And essentially, the prostate bed after prostatectomy should have nothing lighting up. It should be completely clean on a carbon acetate study. This little white thing here, that's a surgical clip. And we'll see those. So there's an area here that's pretty easy to see. It's lighting up with the carbon acetate, very much in the prostate bed. And what's important about this study then was also looking everywhere else. And one of the advantages of these kind of PET imaging studies is we scan from below the pelvis all the way to the base of the skull. So we get the whole body in. And we were able to look at all the lymph nodes, look at the lungs, look at all the bony structures, and it was negative everywhere else. So not only did it show us where the cancer was, but it also gave us very high confidence that it isn't anywhere else. So really helps us direct the treatment. This gentleman then opted to have radiation therapy to the area. It was done a little slightly different than the standard radiation port on there because we could identify the very specific area where it was. So that was they made the centroid of the radiation. He's actually at 5 years undetectable PSA. So this really helped direct the therapy. Now, reality is he was slated to have radiation therapy to his prostate bed as the therapy before he came to us. But it was then going to be done, well, we're thinking it's there, and it's going to be done blind. We're not really sure where it is, so we're going to cover the whole territory. And the success of that when it's done blind is probably only 40 to 50%. What we have found with those gentlemen that we actually find the target, we clear the rest of the body, then they go into that procedure. It's been closer to 80 to 90% success. I mean, and what we're talking about success is long-term PSAs being undetectable or staying very low. Okay, so here's another example. And I don't think this is yours, even though it's in the same spot. So Gleason of 8, on diagnosis, had a prostatectomy in 2010, had shown extracapsular extension, so ECE, and a positive margin. And at the time that we did the scan, the PSA was rising, moving. This one is moving pretty quickly at 3.18 months, but it's still pretty low, 0.5. So here we're looking at the pelvis again, front, back, right, and left. Here's the bladder. This is the rectum. And these two areas here, these are the seminal vesicle remnants. I have to call them that. They're actually seminal vesicles that were left behind by the surgeons, but if I call them that, they get mad at me. So I have to say the remnants or in the bed. And there's clearly an area that's lighting up in the right seminal vesicle bed. Again, the rest of the scan was completely clean, so no lymph nodes, nothing in the lungs, nothing in the bone. And so this very much directed the therapy. Now, for this, radiation therapy was done just to the seminal vesicle. The rest of the bed was left alone. So one of the things to understand with standard radiation is because they often are doing it without a target, they're radiating the whole portion of the lower portion of the bed, and they give it a margin, extend it off to both sides. It looks like a big bow tie, kind of three-dimensional bow tie in the body. Because since they don't have a target, they want to make sure they cover all the areas. And then they also extend into the back part of the bladder here and the front part of the rectum. So if we can give our radiation oncologists a target, they can do their job much better. They can focus in on that area. They still have to kind of cover the whole territory that they're intending to do, but their dosimetry and how much radiation dose goes to different parts of the lower pelvis is very different. And this patient has also done very well. Okay, so another example, a gentleman with Gleason 6 had brachytherapy. So had seeds put into the radioactive seeds put into the gland, and also external beam radiation therapy, EBRT, external beam radiation therapy. That was back in 2000. PSA had gone down pretty well to 0.16, and then started to rise. Now a little bit over 2, fairly slow. We're a little bit higher up in the pelvis here. So this is the pelvic bones here. These things that look white here, that's the intestines. We have people drink a little barium, so we can see the intestines pretty clearly. These are muscles here, so this is the psoas muscle, or the human tenderloin. Blood vessels here, and you see there's this small little area that's lighting up here. That's a small lymph node. On a standard CT scan, we would just kind of blow by that. This doesn't meet our size criteria. it's rounded, so someone very astutely reading the CT, they might come to their attention, but most of the time we would miss that. The carbon acetate really highlights it for us. So what was important here is that was the only lymph node in the pelvis that was identified, at least being lit up. Everything else looked negative on the scan. This gentleman opted to have a salvage nodal dissection. So the surgeon went in robotically, removed lymph nodes from both sides of the pelvis. I think 13 nodes were removed. Yes, 13. And one came back positive by pathology, and it correlated with this one. Gentleman's PSA immediately dropped to undetectable, and he has stayed there at that level since. So different strategy of going after something once we identify it, it opens up the door for some possibilities. That equally could have been radiated, either as a single node or both sides of the pelvis, or could have been watched. There's a number of different ways that could have been dealt with. Okay, so here's an example of where the carbon acetate is picking up on the bone. So we changed the windows on here so I can see the bony structure a little bit better. This is in the lumbar number 1. You can see there's this little spot that's lighting up here as opposed to the rest of the bone marrow. Pretty easy for us to see. Couldn't see this on CT scan. It wasn't available. We couldn't find this on MRI yet. We waited it out, and it became positive on MRI eventually. So that was part of our proof on that. We don't tend to biopsy bone if we can help it. So carbon acetate has been very good at picking up early bone metastases. Usually for this, when we see this, we've gotten a little bit more aggressive about going after oligometastatic disease or few metastases, even if they're in the bone. We usually tend to go after these with radiation now, but that's in the context of starting systemic treatment. So this is a gentleman who he was on, basically had started ADT, and we saw this. So this was a signal that he needed a little bit more. So this was a bone metastasis that was now starting and breaking through his ADT. So this helped us really shift him over to a more aggressive therapy pretty quickly. Okay, so we've had the advantage now that Axumin's been available. We ran about 30 patients where we did both acetate and both Axumin, mostly for my education, because having read now as many carbon acetate studies, how do we or can we apply the knowledge that we've accumulated looking at carbon acetate studies? Can we basically get a lift on the Axumin studies? This is a gentleman, let's see, 69 years old, Gleason 3+4. His PSA was rising. He had a prostatectomy, so good candidate for us to go on the search. Here's the carbon acetate study. All of this is normal intestine. Again, here's a small little spot that's lighting up here. It's pretty small, right next to a blood vessel. Small lymph node on the carbon acetate lighting up. This is Axumin done within the same, I think it was within the same week. Actually done before the carbon acetate, and really can't make out that there's much Axumin uptake there. So very minimally positive. So this essentially would have been right negative. This is positive. So we are seeing that when we compare these things head to head, that the Axumin really isn't performing as well as we'd like. So here's another example. This is a gentleman, Gleason of 8. He had a prostatectomy and also then had radiation to the bed. PSA was rising now 1.1. The top two here, this is the PET CT combined of an Axumin. Here's the Axumin, just the raw data for the Axumin itself. Same patient next day, carbon acetate. There's a small spot in his T5 vertebral body that clearly lights up. And if you really stare at the Axumin, maybe cross your eyes a little bit, you can actually see that there's something there, but essentially it would have gotten missed as well. So what we're finding, particularly with the Axumin, is it actually performs very poorly in the bone. So when I get asked to do an Axumin, I will not do an Axumin if I don't also have a sodium fluoride bone scan to go along with it, because I'm afraid I'm going to be missing things in the bone. Axumin's available, but I'm not a big fan, as you can probably tell from the data so far. Okay, so let's move on to PSMA targeted molecules. So there was 3 gentlemen who have had this in the room. I think many more of you are going to have these in the future, it's just really the future of where I think this molecular imaging is going. So PSMA, prostate-specific membrane antigen. So that's what it stands for. I heard a different way of saying this, which I hadn't heard, which I kind of like, is PSMA. So PSMA, PSMA. So what's interesting about it is not at all entirely specific to prostate. So it's also seen in basically vascular tissues, normal tissues, as well as many other malignancies, many other cancers. Everyone outside of the prostate world actually calls this glycoprotein numeral 3. So we've adopted a name on here that's a little confusing, so we have to be careful of that. So some of the normal tissues, brain, kidney, in the proximal tubes of the kidneys, portions of the intestinal brush border, lacrimal glands, salivary glands, very highly have a lot of these antigens in them. We're not exactly sure what it does, but what we do know, at least with prostate cancer, and in particularly more aggressive or more advanced prostate cancers, this protein is highly expressed on prostate cancer cells. So this is a protein that's sitting on the cell surface, and we believe it has a role in the tumor's invasiveness. Still some work being done on figuring out exactly what it does. But from an imaging perspective, and then we'll also get to treatment, it's a protein that now we are creating small molecule ligands that attach to it. So we can deliver a radiation or a little radioactive material on that protein that lets us visualize it, and then also potentially do some treatment. So detection rates, when we look across the literature, this has been very popular in Europe, Asia, Australia. They're doing a lot of PSMA studies. Almost all of it is gallium-based, and we're going to talk a little bit about that. But when you look at all these different studies, and I think combined they probably outnumber everything we've done with acetate and choline already. So it's really taken off. 80 to 93%. Which is not bad. It's not 100%. And we'll talk a little bit about why that is. So one of the problems with PSMA, or when we talk about PSMA, is it's not one protein. It's not one agent. There are many of them. These are the ones that I think as of about 2 weeks ago, these are all the ones that are currently being studied in clinical trials. Now, none of them are available commercially yet, so none of them have been FDA approved. The one that is the most popular is this top one. It's the gallium PSMA 11. This is the one that is being done at UCLA. They have it at Stanford. They're doing it at UCSF. I think there's at least another 5 universities in the U.S. that now are doing gallium PSMA 11. Difficulty with gallium PSMA 11 is that it is non-proprietary. So it's an agent that was developed, and there's no intellectual property on it, which means there isn't anybody behind it. We can't get a GE or a Lilly or a Philips or any of the big companies to basically put a clinical trial together and support it. So in the U.S., that's a death sentence for us. So if we don't, we're run things very commercially. So if we don't have a sponsor who is going to get a return on their investment, an agent is dead in the water. So what has happened is the university systems have taken on to themselves to make it available, and as a consortium, make it work. But that's going to make it difficult for actually it to get to FDA approval, because someone has to pay the fees, someone has to take charge of it and be responsible for it. So that's something that they've taken the initiative. It's exciting. We'll see what happens with that. The other thing with this is you see that there's different things here. This is gallium on a number of these. This is copper. There's a few of them that are labeled with technetium, this technetium-99, which I don't think those will go anywhere. Those are old technology based. There's iodine, and there's a number that are fluorinated. Now, the problem I didn't really mention, I should have on the carbon acetate, carbon choline. Why is it that my site is one of the only, there's actually 2 other sites that are doing it kind of under the radar, but we're the only ones who are actively doing this, is carbon has a 20-minute half-life. So we have to produce it in the cyclotron. It plateaus. You can only make so much before its decay and its production equalize. So you hit a wall. And with the 20 minutes, we have to combine it with acetate, do all the chemistry, do all of the quality assurance, make sure it's sterile, and all that process takes time, and you have to use it where you make it. So my imaging facility is in the same building where our cyclotron is for our research cyclotron. Mayo Clinic in Rochester does carbon choline. They have the same situation. They have multiple imaging cameras that are set up in proximity to their cyclotron. So the carbon is logistically difficult. You have to have a lot of basically equipment and people to make it happen. And when it fails, if you do have an issue with your cyclone, this and the other, you're kind of done for the day. You have to wait for all the radiation to cool off. So there's just a lot of inconvenience and logistics with it, which also make it expensive. Fluorine, on the other hand, is an agent that has a longer half-life, 110 minutes. There's every cyclotron in the country here, which there are many, makes fluorine every day because we use it for fluorinated glucose, which is a standard agent. We also use it for sodium fluoride. It travels. And so an agent that's tagged to fluorine potentially has an advantage, and that means we can distribute it, we can make it in one place, and if you can fly there within 2 hours, we can get the agent to you. So that also then economically means, with volume and everything else, is going to probably be a little bit easier to use. So the difference here with these gallium and why these have gotten really popular in Europe is gallium is not done in a cyclotron. It's done in a reactor, which is a little portable, essential germanium reactor. And you elute it with hydrochloric acid and other things, and off comes gallium. And then you can use it for chemistry. So much more portable and has some real advantages to it from that perspective. The disadvantages of it are that you can only usually get about 2 or 3 doses off of an elution per day. So it has a limitation of how much you can do. So those that are going to be doing a lot of these are probably going to have multiple reactors that they're going to have. The other aspect really of this is comes from a cyclotron agent. Basically, we flip on the cyclotron, we let the beam run against a target. I can make isotope all day long. Gallium comes from an enriched source out of Norway. There's a limited supply. So as soon as we start really going with gallium, we're going to start finding that prices are going to go up because there's limited supply. All right, so a couple of things, at least my predictions are, there's 3 agents on here that I think are kind of top of the list that for various reasons. Primary reason for the 3 is these are all sponsored agents. So these are owned by various large organizations who have a vested interest in seeing something go all the way through. And so that means they're sponsoring clinical trials that are going to be paid for, and they're going to basically do the science and take it all the way through the FDA. 617, I do believe this one is available at UCLA. This one we'll talk about in a minute. R2 is actually a new one. We're going to be opening up a clinical trial for R2, hopefully end of this year, beginning of next year, gallium-based. Again, all sponsored trials, so that makes it more convenient. The work we're doing here in the U.S., unfortunately, we cannot take what the Europeans and what Australia has done as far as all of the groundwork they've done. We have to start from ground zero. So we have to do dose escalation trials. We have to do pharmacokinetics, all of the basic things to make sure that these proteins are absolutely safe, and we know exactly what the side effects are. That's part of when we do FDA clinical trials. These are the things that we're held to. Yes, sir. So these are all, let's see. So this is an antibody here. So this is actually it's an FAB structure, so it's a shortened antibody. The rest of these are predominantly what we call small molecular proteins. So there's a really good question to understand on that is PROSTATE, which some of you may have had or heard of, was essentially a labeled antibody with indium against the PSMA. The problem with that is it's a big protein, full antibody. The liver basically likes to sequester it because that's what its job is with these big proteins. But in order for it to get to the target, it had to circulate for a number of days. And the target for that PSMA was intracellular. So we had to wait for it to get pulled into the cell, attached to the inside of the cell for imaging. So it was very cumbersome and didn't work very well. Now, all these agents are actually targeting the outside portion of the PSMA protein. And with the smaller the molecule is, the faster it circulates, the faster it actually gets to that target. So the work that has been done in the last few years in making these small molecular proteins has made it possible that we can actually tag it with an isotope that only lasts a couple hours and do the imaging. So PROSTATE in the past, you got ejected, and you came back 3 days. And then you got imaged, and maybe you came back another 4th or 5th day and got imaged, and so really not very convenient. It wasn't very successful. So things to also understand about PSMA. 10% of prostate cancers don't express any, right off the top. So we're finding this out, and that's part of the reason why when we look at the statistics, we're not going to see 100% detection rates. It's going to be somewhere between 80 and 90%. Because if you don't express, if the PSMA is not expressed on the cancer, and even some very aggressive cancers, widespread cancers, no PSMA. So that's going to be a real limitation to it. You had a question? We're going to get to that because these are diagnostics. You're going therapeutic. You're one step ahead. Okay, so now the other disadvantage of the PSMAs, let me actually just kind of show you here. Here's some examples. This is the gallium. This is essentially gallium PSMA 11. This is an iodinated version. This is one out of Johns Hopkins, DCFBC. And what we're seeing here is a normal uptake, lacrimal glands and the salivary glands. So these are the parotids, these are the submandibular glands, so up here on both sides of the face. You see a little bit of liver, you see a little bit of the spleen, you see a lot of kidney, so there's, we call them beans because that's what they look like. Bladder here, so a lot of tracer activity in the urinary bladder. So these get excreted in the urine. Now the positive part of here, you see all these little dots, that's all prostate cancer. And you can see them pretty well. And so it's a reasonable study when we're looking for things, I think, outside of the pelvis. So in this example here, iodine, just a different energy, so you see it's a little bit fuzzier, but the same kind of thing. Lacrimal glands, salivary glands, liver, kidney, bladder. This is a metastasis in the bone. This is a small lymph node. So those are the abnormal areas. In this one here, lots of the vascular system. So you can see the heart very well. You can see all of essentially the major arteries. So this tracer stays in the blood pool, didn't clear out of the bloodstream. And that's pretty typical appearance of it. And again, you've seen the liver, you've seen the kidneys, here's the bladder, and these dots here, those are all prostate cancer. Now I'm showing you these in what are called projection images. We go slice by slice. You get, these are combined with CT, so you get very precise anatomic localization for these. But just to give you an idea of the biodistribution. What's problematic with PSMA agents is the bladder. So carbon acetate, carbon choline don't go out into the urine. Axumin, a little bit in the urine, maybe about 20%. So those agents have an advantage if we're really looking for prostate cancer that might be limited either to recurrence in the bed or if you still have a prostate within the prostate or the lymph nodes that are in the lower part of the pelvis. So these agents are going to be really problematic from that. This is the one I think to keep an eye on. This is a PSMA, a fluorinated PSMA, so it has the right isotope. And it's an early animal model. So far, it's not going out through the urine a whole lot. So it's not ready for prime time, but I'm going to keep an eye on it. And you might all be hearing about it in clinical trials in the next couple of years. But if it pans out, that'll put everything else kind of behind us because it'll be almost the perfect agent. Okay. All right. So. Just a couple of examples. So here's a gallium PSMA 11 study that was done in a gentleman, Gleason of 9. He's had his prostate removed. This is relatively recent, I think within the year of having his prostate removed, and the PSA started coming up, which is a worrisome sign that early rise in the PSA within 1 or 2 years after prostatectomy. So here's again the kidneys, the lacrimal glands, liver, spleen. You can see a little bit of the urine actually in the ureter, so kind of a little line here and a line here, very prominent metabolism excretion into the bladder. This was done at one of those named universities that I named earlier. It was called negative, so no PSMA. We saw the gentleman for carbon acetate, and there is, this is the cross-section here. Well, this is looking from side to side. So here's the urinary bladder here. So notice there's really nothing going on in the bladder as far as accumulation. Here's the bladder from front to back. And there's a small spot that's sitting right in the prostate bed we call the apex or at the anastomosis. So where the bladder was connected into the ureter, into the urethra, into the urethra, and right, very, very common place for us to see recurrences because a little bit of tissue gets left behind, a little bit of prostate cancer gets left behind. And really only a carbon acetate is going to be able to see these. We've also had a few of these go off to have multiparametric MRIs. The MRIs were negative. We biopsied it. The biopsies were positive. So right now, our highest confidence in evaluating the post-prostatectomy prostate bed is with either carbon acetate or carbon choline. So now the idea on these imaging studies, a lot of these patients, we're looking for early recurrence. So we start doing these kinds of imaging studies not after we've seen a bone scan that's got a lot of bone metastases, but when the bone scan's negative, the CT scan's negative, we've got a rising PSA, and we're looking for subtleties. So the prostate bed and the lower pelvic lymph nodes are there probably 60% of where we find these things. So it's the most likely location. And if we're going to guide treatment, we actually have to see it. We have to find it. Still an advantage. Okay, so lutetium-177 PSMA, which was alluded to, is part of the reason I think for the excitement with the PSMA-based agents is that because it is attaching to a protein or expression of a protein on prostate cancer, the idea is then we put a higher energy isotope instead of the imaging isotope like gallium or fluorine or copper. We put something like iodine, like I-131 or yttrium or lutetium on it instead, and these give off a beta particle. So they give off enough radiation that it actually causes cellular damage. So it's a treatment. And we're able to deliver that radiation very specifically, very targeted to prostate cancer. So this is really the direction why PSMA is so popular. Is it's not just diagnostic; it's what we call a theragnostic. It has a therapy component to it. So when we look at, I know this is probably impossible for anybody to read. So the idea on here is to really look at, well, when the studies that have been done, what do we know about it so far? I mean, one of the things that we've learned, for example, with Provenge, we don't watch the PSA, or we're told really not to watch the PSA because the PSA isn't necessarily going to go down, which is a little mind-boggling as far as pretty much every other therapy we use. Our standard is if your Zytiga is working, your PSA goes down, you hope, right? And the threshold for clinical trials is usually a 50% decrease in your PSA. That shows that you are demonstrating a therapeutic effect. Provenge was not held to that because it showed overall survival benefit. So that's why we use it, but I don't think we understand exactly why it works. So when we look at the lutetium, it's really starting to demonstrate some very significant parameters. So looking through all these different studies, this says fall in PSA by greater than 50%. And all of these studies have all shown that there has been a pretty significant drop. And you take them all together, from the highest to lowest, it's about anywhere from 30 to 70%. So we know that when we deliver lutetium on a PSMA, we're affecting prostate cancer cells. We're keeping them from we're destroying enough of them that we drop the PSA. We can also measure, so when we look at CT scan, we use a criteria that's called RECIST, which essentially we're measuring how big a lymph node is or how big a lesion is in 2 dimensions. If it shrinks, we're happy. If it enlarges, we're not. Pretty basic on that. And we also then imaged with a PSMA agent to see whether these showed more metabolism on it. So through these studies, PR is partial response, SD is stable disease, and when we look through these, the vast majority of patients had partial response to stability of the disease. Now keep in mind that, I'm going to show you some images, those who have had lutetium-177 PSMA, these are patients who have a lot going on and typically have done everything else. So the studies have been done on patients who have, they've had definitive therapy, they've been on hormone therapy, and nowadays they've been on second-line hormone therapy, they probably have had at least 1 round of chemotherapy, probably Provenge, probably Xofigo. So they've hit everything, and they've still progressed. And this is showing a pretty significant drop in their PSAs, and also what it looks like on the imaging. The imaging is getting better. So tumors are getting smaller or not as metabolic on a PSMA study. A lot of these patients at that stage are also symptomatic. So they're feeling the bone metastases. And we're seeing that there's a pretty substantial response, probably somewhere between 10 to 30% of those with symptoms that are getting symptomatic relief. What we don't know, and this is still new enough, is does it make you live one day longer? We don't know what the survival benefit is on it. Now, we can pretty much extrapolate based on everything we know about other drugs that when we see this, that there's going to be a survival benefit. But the data's not in yet. And the few studies that are looking at it, well, these patients, for example, this was published in 2016, median not reached, that means pretty much patients are still alive. So they can't calculate what survival is because they're all alive still, which is a great thing. So this is something that we're going to be measuring in years, and so I think it's going to be very important for that. So this is another agent right now. It is I think there's 2 sites in the U.S. that are currently open with a 617 version of a PSMA lutetium, Houston and UCLA. I don't think that there's a number of places that are looking at opening them very shortly. We will have an R2 lutetium 177 hopefully also open by January. We have a lot of work to do. We got to do some of the basics, like I mentioned before, what we call pharmacokinetics, and also some toxicity limits. So they're usually what are called dose escalation trials. We start with a lower dose, more one cycle, then we go with a higher dose, then we go a higher dose, and those studies haven't really been done with these newer agents, and we're going to see that moving pretty quickly into the U.S. So just also, what we are looking for. How do we select these patients out? So here's an example of a gallium PSMA. You can see there's just, compared to those other images I was showing you, you can just see there's pretty much metastases in the majority of the bones in this person, right? So it lights up very much on this. This is that same gentleman with a fluorinated glucose. Now, we do find that fluorinated glucose usually lights up a little bit on someone who has extensive metastases, very aggressive, widespread disease. So it's not that it's useless, but if you look at what you think about the scan and what's involved from here to here, this is a big difference, right? So this also then tells us that in this particular gentleman, a PSMA-based radioactive therapy is going to have a reasonable success. We know where it's going to go, and we in fact use the gallium and PSMA as how we select patients to get into it, and also how we monitor the patients. Now, here's an example of a gentleman who, here's the fluorinated glucose, and it's lighting up pretty well. A lot of the different bones are lighting up here, and here's his gallium PSMA. Just only see his normal structures. Salivary glands, the liver, spleen. This is flipped backwards. His liver should be on this side, but liver, spleen, kidneys, here's the bladder, and none of his metastases light up. So lutetium's not going to do anything here. Unfortunately, to the level that's required for therapy, 20% of people do not express enough PSMA to make it worthwhile to do the lutetium. So although this is really a great direction we're moving in, we're going to still see some limitations. So it's going to be very important for us then to always do the imaging to make sure that we know where our targets are. Okay? And I think that was my last slide. So, questions?
What we're going to do, you can keep that. Over here for questions. Yes, sir. MRIs? Which has more effective resolution, the 1.5T or the 3T?
So 3T is going. Okay, so what has a better resolution, a 1.5T or a 3T? So 3T, inherently better resolution, particularly for small body parts or central body portions. So for hands, ankles, knees, things like that, hips, big musculoskeletal areas, 1.5 is great. I do even 1.2 on an open MRI. You get very good images. On a 1.5, without a coil, without an endorectal coil, you just don't get the anatomic definition that we'd like to see. I think the real advantage of the 3T is, 3 Tesla, is that you don't need the endorectal coil. So I think if you have a 1.5 with a coil, so we actually put in a coil into the rectum that allows us to get the electromagnetics closer to the prostate, we get good resolution. But it's an uncomfortable thing to do. I'm also not real pleased with it, and it distorts the anatomy of the prostate a little bit because we're pushing against the back end of it. it can be a little bit more challenging. I think more and more places are really looking at doing 3T. We are also looking at, I don't like the name of this, so if someone has a better suggestion, I'll recommend it to the vendor, but they call it the diaper coil. Maybe Bermuda shorts coil. Essentially, it's a different coil that we're looking at. A couple places in Florida are using it on 1.5, and they're saying that they're getting as good a resolution anatomic definition as a 3T. So there are many more 1.5 Tesla MRIs out there than 3T. So that's been part of the challenge of getting these done right, is you got to seek out those who have the technology.
The 3T is FDA approved?
Yeah. There's we use 3T a lot for brain imaging, for particularly when we're really looking at small structures, and so those that do a lot of neurologic imaging tend to have 3Ts available to them.
Okay, another question there?
In the results you shared with the PSMA, was that with or without ADT?
For the imaging or for the therapy? Most of those patients are without ADT when we're doing the imaging, because we're looking at it to really figure out what the therapy is. What we do find, though, is, and I don't know if this translates to PSMAs yet, but at least with acetate, if someone is on hormone therapy and the PSA is rising, I don't care how fast it's rising. If it's going up, the test is almost always positive. I think we're at like 98% in about 200 patients. So that if your PSA is rising on ADT, that's got more momentum to it, and we're going to pick it up.
Okay, question here.
Yeah, at Scripps, they check your PSA, the main detector, and my PSA goes to, it's been going up, now it's up to 30. It started fairly low, 20, 30, and when
you and I should talk afterwards. Yeah. So part of it is the context. I mean, I think with any of these, so he has a rising PSA on therapy, hitting 30 now. So with anything else, imaging, the idea of doing imaging is not just to let's just know where it is, just to know where it is. Let's know where it is to see if there's an opportunity to do something different, change your therapy, add something to your therapy. We've had some gentlemen who have come to us who have been on a lot of therapy, and the PSA was rising, and we did the imaging. We found that they actually had local recurrence. They never had metastasis. It was just assumed they had metastasis because we couldn't find it. Take all the medications off, and we reverse course. So we take everything away, and we go after the target, and we've been successful with that. So it really is also, what I would say is if you're comfortable with the therapy you're on, if it's holding the course and you're tolerating the side effects, then that's not a reasonable thing to just continue doing. But if it's rising and we're looking for alternatives, then the imaging can be very powerful.
Okay, question here.
What is the connection between ADT and sound?
You're getting outside of my area of expertise. What is the connection between ADT and Alzheimer's? So, I mean, there's some reports that we're seeing, long-term use of ADT, cardiovascular effects, cognitive effects. But, if you're not eating Brussels sprouts, you might have more propensity for Alzheimer's as well. So maybe a better question for Dr. Lamb next month, because that starts getting into really in his territory.
Okay. Question there.
Do we have any information about whether Medicare or the VA will pay for any of these types of therapies or imaging?
So carbon choline at Mayo Clinic is covered by Medicare. Because they got a single site FDA approval, so there's some advantage of what they're doing there. They do tend to stack it on with a lot of other imaging, so your copay, if you've got one, still tends to be kind of high. So that's going to be an individual thing. Axumin is also being covered by Medicare. At least our jurisdiction here, Noridian, is covering for it. I've done about 30 patients so far with Axumin in the last 2 months or 3 months, and they've all gotten paid for. So nothing out of pocket for the patients, which is great. The private payers really aren't hitting any of these. We try. It's extremely hit or miss. These agents are very expensive. Axumin, just the dose is a little over $4,000. And when you put the imaging and everything on top of it, if you had to pay for an Axumin out of pocket, it can run anywhere from about $5,000 to $7,000. Carbon acetate for us is something that people do have to pay for out of pocket. It's not FDA approved. The FDA asked us to convert our study, which we concluded at 500 patients 2.5, 3 years ago. They asked us to continue to make it available under what's called an extended or expanded access, because they realized there was a lot of value in it. But acetate is also a non-proprietary agent. There's nobody to take it to the FDA. So you have an idea. Taking it to the FDA, filing, just having them look at the paperwork is $1.8 million. And then you have to, and then it's $1 million to keep it on pharmacy a year. It's a lot of money for a specific drug if you don't have a big pharmacy company behind you on it.
Okay, questioner.
I've been, in July I was in Germany, and in September I was in Australia getting lutetium, and I'm scheduled to go back to Australia in December. When can I expect to be able to do it in the States?
Well, I would say this. What's going to be available in the U.S. is going to be under clinical trials, and once you've started having it, you'll need to keep the cycles going through where you're going through it, at least probably for the next year or two. We're so early in the U.S. now with the clinical trials. It's 2 years. I think if we get everything done very quickly, it's about a 2-year process for us to get an FDA approval for it. And almost every protocol that I can think of, at least the ones I'm aware of, having had a dose or two of it would preclude you getting into the therapy. I mean, any of these clinical trials, we tend to be pretty restrictive in what therapies you've had before, because we need to control these kind of things. It's coming. Probably not quick enough for you to shift. So what do you prefer, Germany or Australia?
Well, Australia is almost half the price because of their protocol. It's inpatient in Germany, so you're in the hospital for 3 nights. It's outpatient in Australia.
So I'm going to have a little private conversation. How long do they make you stay there? Because I got to write my new protocol. No. So with these radio therapeutics, we do have radiation safety precautions, because these are beta emitters, which mean you don't glow, but you do glow. So we don't send you home right away. You will set off detectors in the airport. You shouldn't be around nursing women, children, or cats. That comes from thyroid, I-131. They have thyroids. You can actually make your cat go hypothyroid by handling your cat after having thyroid treatment. So just, a lot of common sense things, but it's real. Yeah. So, and you have to control your urine, because your urine is going to be very radioactive. Now, these are all things, we do these all the time with radioactive iodine for thyroid. We're very good at it. So it's not difficult, but it's something to think about. You're going to go through multiple of these cycles. You have to have a place to stay. If you're traveling to Australia, it's 3 days. And that's really, in Germany, they're much stricter about their radiation, and you are hospitalized. So for each cycle, at least 3 days. But, these are the logistics we'll have to work through.
Question in the back. If I was going to write a letter to my congressman about our broken FDA system, what would I say about this imaging problem?
Well, I don't know that it's broken. It's just incredibly slow and expensive. But what I would say about that is, there's some benefits to it as well. I mean, the rigor that we have to do studies for safety just keeps us from going down the wrong direction, particularly where we tend to be more sensitive with anything radioactive than anything else, because a misadministration of a radioactive dose is a nightmare for everybody.
Why are we falling behind Germany?
Less regulations, So they've been able to do this, particularly in Australia. They've been able to get way ahead of us on things because they don't have the regulations that we have at all. I don't know that we'll be able to really solve that. What I would say, though, here, if you've got pen and paper and you want to write something, sodium fluoride has been under what's called the National Oncology PET Registry for the last several years, since 2012. So if you've had a sodium fluoride bone scan, who's had a sodium fluoride bone scan, and it was paid for by Medicare, it was paid for under the NOPR program. That's ending in December, and we're not really sure if Medicare is going to pay for them going forward. There's a possibility that they might not. And that's kind of a scary thing, because going back to technetium bone scan, this is not an option, I think, for prostate cancer patients. That one needs probably a little push from the public, those who have had it, they've benefited from it. It's, I think, a very powerful tool. And of all these things we're talking about here, it's absolutely the least expensive. I mean, I'll be quite honest with you. I pay $150 for a dose. So the rest of it is all on the imaging and everything else. And if I got someone who comes into my facility and they really need one and their insurance is going to pay for it, we just do it. I mean, the economics on it are such that we should just do it. And so insurance companies not paying for that doesn't make any sense. But again, I'll get off my soapbox.
The carbon-11 acetate at your facility now, I know there's out-of-pocket.
It's 3,000. 3, correct. Yeah. We do have a charitable organization that helps us those with financial need, people who qualify. Then so we try to make it available.
Okay, Lyle. I want to ask you a real basic economic question. Why will they pay for a bone scan which doesn't do any good, and they won't pay for a C11-Acetate test which will do the world of good? And I would like to know so that we can maybe pursue a course to change how that gets done.
I hope one day we'll get there, that we will go straight to the test that's going to give us the best answer. As you can see, none of them are perfect yet. So we still have some work to do on that. Part of it is access. Almost every hospital has a gamma camera and can do a technetium bone scan. So there's thousands and thousands of places where you can go and get a technetium bone scan. A urologist, no matter where they are, they can probably find someplace you can get a technetium bone scan wherever you are in the country. You can go to Mayo Clinic for carbon choline. You can come to us in Phoenix for carbon acetate. That's, you got to get on a plane. You got to travel. So that's a difficult proposition as a physician to recommend somebody who walks in your office. Well, first thing you got to do is you got to get on a plane and you got to go to a different state and get an imaging study. And they'll say, well, why isn't this available here? And it starts a whole other conversation. So we're hopefully getting there. PSMAs, whether it's gallium or fluorine, will become something that's much more available. We're just not there yet.
How much does a bone scan cost?
About 700. 700. Get down to 350 depending on how you negotiate, but
test cost if it was in the same volume was available.
We would hope it would be less, but the actual process by which you make carbon acetate significantly much more difficult. People, resources. You have to have a cyclotron, and technetium comes off of a generator, which is a molybdenum generator. It's much more like gallium. So that's why gallium, there's the sense that maybe it'll be something we can use easier because, well, I'm going to be doing gallium and I'm going to have my own gallium generator in my office. So I can do 3 elutions per day. And if I do more than that, then I have to have 2 of these. The disadvantage of using a reactor like gallium or molybdenum is you pay for the whole thing up front. So if you use it and you're milking it and you're basically eluting it every day and you're getting your doses off, great. If it sits there and you don't use it, and these are tens of thousands of dollars every 6 months to basically get a fresh one. So there's other logistics and other financial aspects we have to worry about. But.
Okay, question over here. All right, let's switch over here. Mary's question there.
Hey, have you done many C11 for recurring prostate cancer, that you've already done the C11 once and done it again, and
Yes. So two scenarios. If after a period of time treatment was done, or if someone basically didn't get to treatment, in either scenario the PSA is continuing to rise or starting to rise again, we go ahead and look. We'll do another carbon assay. Our protocol allows us to do that. The idea really being is there's some patients who will maybe see a lymph node. They'll have the lymph node radiated in the pelvis. A year or two later, PSA starting to come back up. Take another look. The next lymph node up in the echelon is now positive, and we may go after that. Or at least we want to know. I find that it's very rare for something to go from, for example, local disease, and particularly if it's treated, and then with the PSA rising, for it to be, now it's all over the place, and it's gone very, very widely metastatic. This does tend to move slow. The other scenario we do in, and this is mostly something that I'm accommodating Snuffy Myers, at least initially, we started doing this. He wanted to prove what's called NED, no evidence of disease. So if anybody's familiar with his protocols, has a fairly intensive protocol of traditional therapies, a lot of supplements, a lot of other things that are basically what he's looking for is growth arrest. And he's been able to get some people we've imaged, they've got a lot going on, and he gets their PSAs down to undetectable for a period of time, and he wants to make sure before he starts pulling all the medications back one at a time that we can document that the disease has gone away and that we haven't been masking it somehow with the medications and getting a false read on the PSA. And there's some people whose cancer doesn't make a lot of PSA or does it over time. So we've done post-treatment treatment response imaging as well. I don't tend to do those a lot because for the most part PSA is pretty reliable. And if you've got a good response to the PSA and it's holding down, we image, you usually find that it's negative.
Okay, question here, Ron.
With the gallium-68 agents, what is the relative risk and radiation load to the patient compared to other agents?
So all of these are relatively short half-life. So whether it's fluorine 18, which is 110 minute half-life, carbon with 20, and gallium-68 is 68. It's just kind of weird that it's the same number. The half-life is its anatomic number. So short half-life isotopes, good. I mean, those are basically, they decay out in you pretty quick. Most of the dose from these scans comes from the CT. So that you're going to get the equivalent, we use millisieverts as a number. It's going to be somewhere between 20 and 30 millisieverts for a whole body scan. That's about the same as if you got a diagnostic chest CT. And that's also about the same of getting like 200 chest x-rays. So we don't like to do these over and over and over, because it is exposure. We do a lot of techniques where it's called low-dose CT. So we keep the CT dose down as minimal as possible. In our shop, it's more like 10 to 15 millisieverts. It's about half. I don't go above the skull base if I don't have to, because I don't want to expose your corneas to X-ray radiation. And the likelihood that you've got something in your brain from prostate cancer is almost zero. Not zero, but pretty darn close. So we have to be careful. So these are not imaging studies we repeat on a weekly basis as a monitoring test. So the gallium itself, the agent is attached to PSMA. So if the gallium itself stays attached to PSMA, it's going to come out through the urine. If it dissociates, it will go to the bone. So gallium itself is almost like a calcium tracer. We used to use gallium as a bone tracer in the past. The idea, though, on these as part of our quality assurance is we make sure it's a 98% tag. So that means it goes out through the urine.
Okay, I have a question for you. Post the diagnostics, what treatments have been effective in your observation of these hundreds of patients that you've examined? What kind of salvage treatment seems to be more effective? Care to comment on that?
Okay, so that has been really, that's the million-dollar question, really is. So we do all this imaging, great, we find it, but the idea is we do something about it, and we want to make sure whatever we do about it is successful, right? So part of our strategy, and why we did this in a more private organization, is it's all comers. So we're not restricted like to the university by the urologist or the medical oncologist or the radiation oncologist kind of guiding what comes in and out our door. The advantage of that has been I've worked with all the universities and a lot of the major players in prostate cancer. And so the net effect of that is I've seen every therapy that possibly could be done. We've got NanoKnife, a lot of CyberKnife, proton therapy, HDR, and one that's probably a little bit outside of the box is robotic complete pelvic and retroperitoneal lymph node dissection. We learned a lot from that, both good and bad. So what I would say is my lean, at least for local disease, is radiation. Part of that comes from that experience with having things removed is that even the best surgeon remove 200 lymph nodes, they get the positive ones out, one's left behind. That's been, we're following patients, they, one or two get left behind, they get almost all of it. But then we have to go after it with radiation. What has been interesting, I was talking to Ron about this because he actually asked this question specifically, is that with that surgical experience, we found that those patients who had local lymph nodes have not metastasized. So these patients we've now been following for a couple of years, we were able to define those patients who had node-only limited disease, who were truly limited disease, and the lymph node dissection was able to prove that. We also underestimated how many lymph nodes were positive. So under the microscope, more of them were positive. I think my extremest example was I saw 3 nodes very positive on a patient. They did the node dissection, and 189 of 190 nodes were positive. Every node just basically was positive, but it was microscopic. So that told us, well, that's the one gentleman who he hasn't metastasized, but he's got the propensity to do it. So he got much more aggressive therapy. But what that is, at least in my mind, and we got to write this up, is that helped us map out the lymph nodes. And that information is going to be exquisitely useful for the radiation oncologist as to guide. If we see lymph nodes in a certain area in the pelvis, how do we go after it with radiation to cover those same areas? Radiation has the advantage that we use the imaging integrated in, and if I say there's a lymph node next to the rectum, they can go after the lymph node next to the rectum. The surgeon isn't going to do that because it's too far away from, if you're doing this robotically, they're not going to get it. And so being able to do that. Now, the flip side of that is toxicity from radiation, bladder, rectum, bowel. We always have to be careful. We haven't seen too many recurrences of what we call in-field radiation. So with the area that was treated, very rare for me to actually see the lesion still there. When people progress or come back, it's usually right outside of the radiation therapy field. So I'm kind of leaning towards that, at least for the local disease. Otherwise, as far as what's been interesting for us is we've already been involved with Provenge, with Keytruda, and we've been done imaging before, and we've done after. And when Keytruda is working, for example, it shrinks up. And the PSA might not go down a whole lot, but we see tumor response, and that's been exciting to see.
Okay, we have a question over here. Okay, a question here. Yes. No.
Can you comment further on the change in metabolism for glucose? That seems to be a real puzzle.
Yeah, because we're okay. So another hat. I'm actually an internist that does imaging, so I'm dual trained. I actually really tell too many people about this because then everybody wants me to take care of their cardiac issues. I mostly do their prostate, but I also have spent a lot of time working with integrative medicine. So, and sugar is a big deal. For most cancers, there's this thing called the Warburg effect, which essentially the glucose receptors, GLUT1, GLUT4, GLUT5, they're upregulated in most cancers. So they draw in the sugar, and that sugar is used as part of the primary metabolism. So lowering the sugar, most cancers, you have an effect. Prostate cancer doesn't image with the sugar. It doesn't do it. We don't, and actually FDG imaging is taking advantage of Warburg effect. That's the principle of it. So I question sugar in prostate cancer. Now, somebody tells me, well, then I'm going to eat all the sugar I want. I say, well, that's not good for your heart, and that's good for your colon cancer, your lung cancer, everything else, so I wouldn't do it. But I think fatty acids and other nutrients might have a little bit more of a specific impact on prostate cancer. Carbon acetate imaging, choline imaging, we are measuring lipid metabolism, fatty acid metabolism. And so I tend to, that nutrient or that aspect of it, I think is important. I think what it comes down to is what Moed always says if it's good for your heart, it's good for your prostate, as far as nutrients and diets and supplements and all of those kinds of things. I'm not real big on any extreme, and also it's individual. Some people just need protein. Some people, I think there's good fats. So kind of an Asian Mediterranean combo, and then what actually tastes good. You gotta, I'm a foodie. You can't just go cold turkey.
We have time for 2 more questions. Yes, sir.
I have a sclerotic lesion in T11, and that was detected by the gallium scan in San Francisco. However, going back and looking at my carbon-11 choline PET CTs at the Mayo Clinic since 2014, it showed up on the CT, but it never picked up any of the carbon-11 choline. Do you have any thoughts about why that's so?
Well, you were supposed to send me those images, and you didn't, because I was going to look at those, right? Different, that's something we see. I think more, there's some PSMA positive bone tumors we've seen that are actually not tumors. So vascular things. So we've seen some very clear, obvious false positives with PSMA in bone. We see false negatives when there's a low volume of cellular material. The actual cancer itself is not really the sclerotic area. It's not where you see the scar in the bone. It's around the periphery. So you might have a very, very thin. Well, that's the sclerotic. That's the only thing you can measure. So 1.2 centimeters. So that's still pretty small. You're talking about something the size of my fingernail. But the cancers is usually a perimeter around it. It's not that's a solid thing. And what we see on a CT scan is the scarring that goes on the bone in response to the cancer. So this is something I think we find that for one individual, the carbon acetate, carbon choline is going to surpass the PSMA. In another individual, the PSMA is going to surpass the carbon acetate. We're going to have difficulty with bony lesions with all these to a certain extent. And I have seen enchondromas, which is a benign cartilaginous thing within the bone, very common, see them all the time, light up like a back of the room from PSMA, and that's not a good thing. So we still have some things to learn on which one's going to be better. I still think at least having a sodium fluoride, good quality bone scan on that would hopefully clarify that, or at least add information to that.
Patients that you see that have those and then have radiation, do they get a PSA response? That you know of?
Well, we haven't started our clinical trial yet, so I can only speak to other people's experience with it. And I think when it's acetate, choline, Axumin, or PSMA, since these are not looking at the bone matrix, they should reduce if therapy is working. So we should expect to see a measurable metabolic response with those agents. And this is why they're going to be, I think, they're going to be good, is we can actually use them. The PSA is not telling us the answer. Sometimes people have what's called a PSA flare. You start therapy and their PSA skyrockets. It's because the cancer cells are releasing the PSA, but the cancer cells are actually dying. And we can see that the imaging looks better despite that PSA. We know they're having a flare.
We got time for one more question. Yes, sir, back there.
The proton beam therapy and radiation, when you said you like radiation as proton beam, do you think is good or better? Or?
It depends on what you're targeting. So I think the prostate bed and the prostate, because it's in the center of the body, and the way that whether you do external beam, what's called IMRT, standard therapy, or proton therapy, they're probably pretty equal. Carl Rossi would tell me and show me that he can do things more precisely, and I don't disagree with that. When there are lesions in particularly difficult locations, next to the rectum, next to the spine, next to a major organ, I way prefer proton therapy. Its ability to get a radiation dose into a small area precisely without collateral damage is superior. And I've got a number of patients who we had lesions where I sent them to my radiation oncologist to do IMRT or even SBRT, so a little bit more focal, a little bit more hypofractionated, less fractions. And they said, no, I'm going to burn the rectum. I'm not going to do that. Send them to Carl. He took care of the problem, and great results. So going back to it depends on where the lesion is.
Okay, let's thank Dr. Almeida for